Here we are.
Hey,
Hi, Mario.
Tao. How are
How are
you,
you?
man?
I'm very good, thank you. And you?
Fine, fine. Here in Madrid,
Yeah,
and
no. Are you in Madrid now?
I'm Madrid right now. Yeah,
Okay.
I glad to see you so many years after, man.
It's true, it's true. I was thinking it's about 10 years since
Yeah,
we were together in the basal courses for neuroradiology, for
uh,
diagnostic neuroradiology.
absolutely.
Well, Mario, thank you so much for joining these NeuroTalks. You are the first one. And I'm also the first, this is my first experience as well, broadcasting on Instagram. So thank you for being on board. Um, so the idea of these Neuro Talks is just to have a very informal chat on specific topics on interventional neuroradiology. So we don't want it to be a very formal lecture, a webinar or something. It's a chat between doctors and with specific subjects. And I know that you have been using radial access approach for interventional neuroradiology for these procedures, and so I would be very happy if you could share your experience on that with us. But before that, just let me introduce you to the people that are already live with us. So Mario is the head of the Interventional Neuroradiology Unit at the University Clinical Hospital of Valladolid in Spain. He's a very experienced interventional neuroradiologist, has been publishing very often, and also has been talking in numerous international conferences. So it's an honor for us to be with you today. So about this radial approach, why have you been starting using it, and why? What do you think is really what's the benefit of it from your perspective?
Well, Tiago, thank you. Thank you for inviting me. A pleasure. And let me say you hi to all our friends which are already connected. Well, we start from I think remember like 3 years ago using the radial. And I personally start because one of my patients asked me about it. And he told me, doctor, why don't you go directly from the wrist, which is closer to the brain than the groin? And that's true. And that's true. And at that time, I shared the Angela with the cardiologist, and we shared the nurses. So they showed me how to do the technique. So we start with the diagnostic angiographies, practicing. And to be honest, from the beginning, they were very frustrating because at the first cases we failed. We did some ground punchers. We need to move to the femoral. It's always the same stuff. But at the end, the benefit for the patient is tremendous. You can do an angiography. I don't know how are you doing there, but you can do an angiography and the patient can be discharged from the hospital in 4 hours.
Okay.
And it's not only in terms of discharge, even the experience of the patient inside the hospital is completely different because you are giving the patient the independence to go to the bathroom, to go walk around with their families, and so the personal experience is really good for the patient.
Yeah. So are you doing now all your diagnostic procedures on radial access, or you are sharing? What's the proportion of it
Yeah,
for
whenever it's
for diagnostic?
for diagnostic, whenever it's possible, and I mean it has a good radial because we are doing ultrasound in every single case, so we
Okay.
we expect to have at least a 2 millimeters radial artery. So if it's possible, we go directly 100% of the cases through radial,
Okay.
100% of the cases.
Okay. So you are the way you are testing the arch of the hand is by ultrasound. So you are not doing the Allen test or the pulse oximetry or something.
No, we are not doing anymore. We counsel with the cardiologists, and they told us that they are not using it anymore. We are doing a good angiography. I do a good echography ultrasound, and it's one of the good parts to be radiologist. You can analyze. Let me show you I don't know if I can do this.
Yeah.
And I don't know if you can see properly, but this is the typical ultrasound of the radial, and you may be very good at diameters, and this is the anesthesia going around the artery, so you can do it very precisely. So we don't recommend to do any puncture of the radial without ultrasound. So
Okay.
if you guys are starting, or one of my the main benefits is to use the ultrasound for sure.
Okay. So you have a machine in the room, or?
Yes, we have an ultrasound dedicated for interventional procedures, yes.
Okay. So if you think of all these angio labs that are not fulfilled with all these capacities that you have, and if you don't have an ultrasound machine, would you recommend anyway doing these more? Because vascular surgeons do the Allen test, for instance, or sometimes I think they don't do anything. So would you recommend just on this clinical approach to the permeability of the arch?
So let me tell you. So Allen test is going to tell you if something happens in case of occlusion.
Yeah,
it's gonna have something in the hand. That's correct, no? And it's chemical event. So doing an ultrasound is different story. Is to measure the radial to see which sheath exactly can you put into the patient. If you can do a 5 French, 6 French, 7 French, or whatever. So it's not only to study the collaterals. It's also study the diameters and the properties of the radial.
Okay.
If you don't have nothing, for sure, Allen test should be recommended.
Okay.
You don't have nothing.
Yeah, and probably for diagnostic purposes, if you are using a 4 French sheath or something, you might it might be okay if you just do the Allen test or the. So regarding the technique, are you using the right or the left axis?
So we are using the right side always because it's more comfortable for us to be close in the same position of the regular cases. So we are doing through right. The only case that we are going to the left is if you want to catheterize the left vertebral artery, then we go through to left. But I would say that this is 1% of the cases. So 99% of the cases we are going through the right.
And which using then after that?
Yeah, so we always use the same catheter. We use the Siemens 1 or Siemens 2 for Terumo, the black ones, which are very hydrophilic, as you know, and very soft. And this is the better for doing this. For regarding the puncture, we recommend use the short needles, the micro needle needles, like these ones. For example, you can do some micro puncture needle, or you can do a separate sheath that includes the short one. And this is the main difference. You cannot use the typical femoral needle because you're going to fail a lot.
Okay. And so these are the radial kits that are sold already specifically for this access that the vascular surgeons as well, they use as well. So are you using 4, 5, 6, 7 French sheets or no? 8. Okay.
Even 8.
If you have 2 millimeters, you can put an 8 French sheet.
So we have the threshold for us to put an 8 French is 2.5, 2.6 millimeters. Is the radial is less than 2.5, 2.6, we also go through ulnar artery, which usually measures a little bit more. So we combine both.
Okay. Oh, that's nice. And are you using any antispasm product to avoid prophylaxis?
Yes.
What are you using?
So let me show you. I can show you some images if you want, Thiago. So this is the typical protocol that you use. Of course, use ultrasound as I told you, and our cocktail is with the 73,000 units of heparin plus 1 vial of verapamil, 1 nitroglycerin, and everything diluted in blood in 50 milliliters of blood. And with this radial artery usually dilates 2.2 or 0.2 or 0.3 millimeters, which is a lot usually for doing this. You can use this type of homemade positions. That's as we are start using it, and if you can have more budget, you can use these dedicated tools, which is
Okay.
impressive. This is our lab, and you may see how is the position of the arm, the hand, and also we have a table for how everything in place. So for us, it's really comfortable to work that way.
Okay, so when are you starting fluoroscopy? Are you when the wire and the catheter is already in the brachial artery, or is it possible for you to move the arm as far as the radial artery?
But let me show you this because it's a nice question.
Oh,
So
okay.
here's the puncture, which is made by my colleague Michael Sula, which is already connected. And I'll say him hello, Mike. And he's doing the puncture here. You see here the micronodal puncture is inside the radial artery. You see the reflux. He made the puncture with an ultrasound guide. And once is everything in place, the puncture, you need to move the arc, and this place in this type of angulation. You see the head is here, so you angulate the table to have the arm, all the arm here, and allow you to do a proper, as here, roadmap or a DSA or whatever. So you need to move the table. Is the best way to do it.
Yeah.
So once you have this, you may introduce in this case it's fine French sheath.
Yeah.
And if you do it properly with this technique, it's super safe to do it. And whenever we can, we use the distal radial approach at the level of the snapox. Let me show you here some. And after that, the injection of the cocktail that you told, you can change it. In this case, we are exchanging the 5 French by an 8 French sheath.
Okay. That's for a stroke or for?
This is for a stroke, exactly. And through the 8 French, you can introduce, as you know, balloon guide catheters. We are using the flow gauge through, and this is a good tool for. And this is the final position. You see the radial, for the people to identify the groin here. So you are working even in the best position for us in terms of radiation. So it's good.
Yeah, because for stroke, we can always think that we are going to close the artery anyway with angioceal or start close or something like that. What are the main advantages for you for going through the radial? If you are going, for instance, for the left carotid, for instance.
Yeah, so the point is we are only using radial in 10% of the strokes. The last year we did 2,030 strokes at my hospital, and we perform 24 strokes by radial. So the indication will be in a case of really complex angulated common carotid artery or bovine arc or similar. So what we usually do is study very carefully the CTA before. And if we think that it's going to be last for us more than 30 or 40 minutes, they go directly through the radial. And it doesn't matter let me show you here. This is the 8 French balloon guide catheter through the 8 French sheath. And here, for example, here is the left carotid. And you may see the navigation of the 8 French balloon guide catheter, even in a good way, considering that it's the left. So.
Yeah. That was a select catheter?
No. This is do you mean the inner one?
Well, yeah, the purple one that I was.
Well, I don't know. Maybe it's a Siemens one, or it's the proper inner of catheter of the flow gate.
Select.
But you see here the flow gate here navigated really up. Yeah.
Oh yeah, now it is. Yeah. Okay. I see.
From the indication, as you told, is let me show you. For example, a typical case, a good case for this could be this one, super tortuous anatomy on a very angulated of right and left common carotid.
Yeah, and are you going through the carotid direct approach to the carotid artery?
We did it for sure. More often years ago,
yeah. Sorry.
We are not doing anymore the direct puncture since we are using the radial.
Yeah. Because the carotid puncture is not as simple. Well, simple it is. It's not just as safe,
No,
probably.
and if you have patients that with IVTPA, doing a carotid puncture is a little bit risky, don't you think?
Yeah.
So for radial, for example, if you close the device like that, you do the angiography and then or the thrombectomy, and then the patient can be discharged with this. So you cannot compare this with a direct carotid puncture.
Yeah. So even with 6, 7, 8 French sheets, how do you close it? You just don't close it. You just do some pressure, and
Yeah.
do you put a wrist brace or
Yeah, we
how do
always
you?
use the two different bands. So what we are doing first, and this is a good point, is when we
Okay.
finish,
Yeah.
we cut everything with you see here with a scalpel.
Yeah.
Try to avoid in any movement of the sheath. Okay, and after that you have two different bands. You have this one which is from Terumo for proximal punctures, as in this case, which is good, and it's a hydraulic mechanism, so you may inflate directly and remove the sheath very easily. You see here. Okay, and for distal cases, you have a different one, which is this one. This is from Merit, and this is for distal punctures, like in this case. This is a ballast catheter, and we puncture directly the distal radial artery, and this is the different way to close. So we are using these two different closures, which is hydraulic. So you leave the patient 4, 5, or 6 hours during this compression, and then you can pull it out.
Okay. So they do that at the ward after.
Yeah.
Yeah. So not you, not
No.
radiologists.
We are
Everyone
doing.
can do.
We are doing
Oh,
that.
you go there.
Everyone,
Okay.
absolutely,
Okay.
absolutely. And let me show you. This is an ulnar puncher in a case with a small
Yeah.
radial, and well, it's the same technique and it's the same band, so it's exactly the same.
Okay. What's the diameter for the ulnar artery? Is it the same size as you are using?
Yeah. Yes.
Okay.
Yes.
Okay. Well, yeah. So for those people that are watching us and don't know exactly how to start it, what would you recommend? What would be your advice? How to start doing that in an department that no one is doing?
Yeah, but this is a nice paper to talk about it, and talking about the impact of the operators on the experience of radial punctures. So, and they saw that you need to do at least 100 cases to have a good experience and to decrease the number of complications. So, well, if just somebody wants to start doing the radial, they need to start doing for sure diagnostic. And after doing 100 diagnostic angios and with a good technique and no failures, you can start using and improving and doing more and complex cases. So a stroke could be the last one in doing that, because you need to save time. So you need to practice a lot. We are doing a radial puncture in 4 or 5 minutes. So we are super fast doing that. But after we have done this case this year, we did more than 150 intervention by radial. So at the end, all the staff have a lot of experience. So I will say that you want to start is to start doing diagnostics.
Yeah, that's pretty much what I think we need to know. I'm just going to ask you, what complications did you have already?
The complications are super low, and we have two spasms. I think you have the numbers here. We have one spasm, I remember, and two spasms, one not significant, and the other one with entrapment the catheter. So we need to put some warm and some anesthetic around, and with no complications. So the complications comparing with the femoral are significantly lower. So you see the type of complications comparing the radial and femoral, as you see, it is impressive. I mean, the number of radial complications if you do a good technique, it's super low.
Yeah, yeah.
So the most challenging complication could be a pseudoaneurysm. But if you do a pseudoaneurysm, it's because you are not doing a good compression. So in the last 200 cases, we don't have any complication like that. So it's super safe. It's super safe.
Yeah. And it's very easy to compress, so the chance of having a pseudoaneurysm is very low.
What is frustrating at the beginning is where you start doing the case and you see that you have some spasm after puncture and you cannot continue and then go to the femoral, but you need to be constant. You need to be constant, and believe me, do 100. And after 100, you should be super confident in the technique.
Yeah, yeah. Well, Mario, we are committed to be 20 minutes in this conversation. So this is supposed to be a 20 minutes conversation. We are already there. And I think we have already understood the basic of a radial access approach and what we need to know. I would ask you if you could send me the paper that you have just presented, then I can put on one of the posts on these profiles so people can have a look. And are you the author of it?
No, we are preparing a paper of a flow gate. We are not the author of this one. Okay. We are preparing a one. There are some questions here, Thiago.
Oh, right. Oh, sorry.
Which size do you consider as a small radial for using the ballast? Okay, in our case, 2.5 millimeters to use it. So we are using ballast in 2.5 millimeters or more. Okay. So there's another question. Do you give me that, Solam? Well, we usually do this under sedation, minimal sedation. Of course, a stroke will be recommended general anesthesia, and of course, local anesthesia. This is the one that we are using. Okay. Yeah. I don't know if this is more questions. I think no.
If there are questions, we have 35 people watching us now, so which is very good. So if there are questions to Mario, just take the opportunity. Otherwise, we are going to see you talking about this and about many other subjects very soon. Are you going to participate in any webinar? Well, I know that you have been talking about distal flow diversion recently, and are you going to have any other webinars we can watch?
Yes, we are waiting for organizing two different webinars, probably for South America, and one for stroke and one for flow diversion, and probably one about AVMs next month. So at the end, webinars are here because we need to change the way to present, man. Let's see what happens with the meetings during this year. So
here our follower Diakir is asking which size radial diameter do you prefer for 8 frames? So you have already.
Well, if as much as possible. We have our work, and we have a lot of patients that have in Spain at least even more than 3 millimeters. So 3 millimeters will be perfect. But we are using it even in 2.7, 2.8 because the artery dilates a lot. So the point is don't to use the 8 French directly. You put the 5 French, do the cocktail, prepare different stuff, and you give time for the artery to dilate. Then you go and exchange by the 8 French.
Yeah. Okay. Well, thank you, Mario, so much. Thank you for being the first one. And I hope we are continuing next week with some other experts. There's another question. Are you able to?
Okay. Yeah. Do you prefer balloon guide catheter or long sheath? Well, it depends. For a stroke, we prefer balloon guide catheter for sure. But we analyze the data. We have seen that the balloon guide catheter, the current one, usually kinks in the right side. So for a stroke, I would say balloon guide catheter for the left side, and for the right side, a long sheath like the ballast or the Neuromax. The ballast is the better one because you have a double braid and kinks much less than the others.
Okay. Yeah.
Do you see any particular compression device, Tiago? Yes, we use a. I think that you didn't saw it before. Let me show you. We are using some band compressions, and like this one. This is the one for Terumo for proximal occlusions, for proximal punctures, and this is the one from Merit for distal ones.
Yeah. Yeah. So that goes to the next question. Diaki is asking if you are using distal or proximal, and you are using both, basically.
Okay, so if you can do it, it's safer to do it distal. You have less chances of damage the collateralization. So if you can do it, distal. If not, you need to go proximal. So it depends from the patient.
Yeah. You are never using humeral access anymore.
If not needed, no. But you never know, man. You can just break it.
At some point.
But listen, I prefer to use brachial, even brachial, than going to femoral, because at the end, changes a lot for the patient.
Yeah. Well, Mario, thank you so much. I think we are ending this transmission now, and so I hope I can have you here in the future again, talking about
my pleasure, Thiago.
Anything. Okay, thank you so much. See you next time.
Thank you
for everyone that have been watching. Thank you.
Bye, my friends.